So it's my great pleasure now to invite Dr. Danielle Sorrano. She is the nephrologist in our team, so she will enlighten us about the kidney.
Good morning. Hello, everyone. My name is Danielle Sorrano. I'm one of the pediatric nephrologists at Children's, and I've been asked to give a quick overview of how we assess kidney function in our pediatric patients, particularly those with colorectal malformations. So first, I have no financial disclosures. And so today we're going to go through very briefly. I'd like, by the end of this short little talk, I'd like everyone to be familiar with what our kidneys do, recognize concerning symptoms of kidney issues in pediatric patients, and then know practical guidance to preserve long-term kidney function, particularly in children with chronic kidney disease. So we're going to go over the basics of kidney vocabulary, which I actually think is pretty important because it can be, I think, very daunting and intimidating to people. How we assess kidney function and knowing the basics of kidney anatomy. How we assess the role of if your children's kidney function is normal as they grow and develop. How do we recognize chronic kidney disease in childhood? And then again, practical guidance for children with chronic kidney disease. So first of all, urine kidney vocab. I think this is important. You know, my mom is a science teacher, smart, educated, and when I was a medical student, I decided I was going to go into nephrology, and I told her I was going to do peds renal. And I found out years later she was telling all of her friends I was doing peds rectal. So I think that there can be some simple vocabulary issues when we talk about the kidneys because not too many people know what they do. And of course in medicine we have multiple words that mean the same thing. So very briefly, when we say renal, that is just Latin for kidney. And when we say nephro, that is Greek for kidney. So it means the same thing, and you'll hear us use them interchangeably. So sometimes I say peds renal, sometimes I say peds nephrology, but it means kidneys for kids. Chronic kidney disease is known as CKD, and this is irreversible and progressive chronic kidney disease that does not go away with time. Acute kidney injury, or AKI, is sudden kidney injury, and it is hopefully reversible. And then importantly, there's some older terminology. So we're trying to get away from the term renal because most people, to my mom's point, doesn't necessarily know what renal is referring to. So chronic renal insufficiency is the old school terminology for what we now call chronic kidney disease, and acute renal failure is the old school terminology for acute kidney injury. So depending on the resources you see or the physician who you might be talking to, you might hear some of these older terminologies, and they mean the same thing. And then importantly, KCUT, or CACUT, however you want to pronounce it, is congenital anomalies of the kidney and urinary tract. And this is this umbrella term for anyone with chronic kidney disease secondary because, you know, their pipes, their ureters or their bladder or their kidneys didn't form correctly. And so particularly, this is important to today's conversation. A lot of children with colorectal malformations have CACUT as part of their underlying problem. And so just a quick heads up, many adults have chronic kidney disease. About 1 in 8 Americans has chronic kidney disease. Most people don't know about it, but if you see anything on the internet about chronic kidney disease, it is absolutely going to be geared towards adults unless you specifically find something geared towards children. So be careful about what you read on the internet. I mean, it's great to be informed and please look into things and inform yourself, but just know that if you see something, it's probably geared towards adults. And the two most common causes of chronic kidney disease in adults are really high blood pressure and diabetes, and that's not what we're talking about usually when we talk about children with chronic kidney disease. And this is, you know, Pediatrics 101. This is a golden rule for those of us who train as pediatricians. Children are not little adults, so it's not the same disease process, but in a smaller patient, it's a completely different disease, really. And so childhood kidney disease is very different than adult kidney disease. So what do the kidneys do? So first of all, the kidneys clean, filter your blood. They take care of volume and blood pressure control. They regulate electrolyte balance. Electrolytes are the blood salts that are very important and keep all of our bodily functions kind of running smoothly. Acid-base balance, so this is probably the number one job of the body is to keep the level of acidification in our blood very narrowly controlled. And so the kidneys and the lungs are kind of like a teeter-totter, and the two organ systems regulate acid-base balance very closely. The kidneys secrete epogen, which tells your bone marrow to make red blood cells. And then the kidneys also take inactive vitamin D, which you get from either your diet or from the sun, and convert it to active 125 dihydroxyvitamin D. And so that's really important for healthy bones, particularly in growing children. And so if we look at the kidneys, first of all, most people have two kidneys. They're located in your kind of lower mid back. And it looks like this kidney shaped, a bean shaped organ, and you have one on each side typically. And if we kind of zoom up here in the cortex, or the outer part of the kidney, you see these little kind of, they look like raspberries. These are little capillary tufts that abut into what we call the nephron. And each kidney has about 1 million of these nephrons. And so the nephron is the functioning unit of the kidney. And there are some component parts. So one is the glomerulus. This is the filter. And then the rest of it's the tubule. So once your blood gets filtered across the glomerulus, now we have urine. And the tubule processes the urine like a water treatment plant. And so this is where the electrolyte balance occurs. And this is where, if you need to concentrate your urine or dilute your urine, all of that occurs. So there's the proximal tubule, the loop of Henle. I'm such a geek that I love the loop of Henle so much, I actually named my dog Henle. So if you hear him barking, that's the namesake. And then distal tubule and the collecting duct. Now the collecting duct is particularly important for children with K-cut or chronic kidney disease secondary to colorectal malformations, because the collecting duct is where we are able to concentrate our urine. So for example, if I stayed outside all day and did a bunch of yard work and didn't take in a lot of water, my kidneys would know that I needed to conserve fluid throughout the day, and they would make a very small, highly concentrated amount of urine. Versus on the other hand, if I stayed inside, it was nice and cool inside, and I just drank, liters of water because I was just, drinking water or whatever my favorite beverage is, my kidneys would try to get rid of that extra fluid and make a large amount of dilute urine. In children with congenital anomalies of the kidney and urinary tract, often these collecting ducts can't concentrate and dilute urine very well. And so regardless of your hydration status, you make kind of a fixed amount of urine. And that's important, particularly when kids are prone, if they can't follow their thirst, or if they're hot, they can get dehydrated because their kidneys can't conserve water. So it's really important that our children with chronic kidney disease stay well hydrated. So how do we assess kidney function? Well, I just showed you the nephron, and I said there's a filter and there's a tubule. So it's actually just that simple. We want to know, are your filters filtering and are your tubules tubuling? Remember, this isn't one filter. This is the accumulation of all 2 million nephrons that you have, 1 million nephrons in each kidney. It's important to know that some people only have one kidney. That's usually fine. As long as that kidney is healthy and working well, you should be just fine, and the kidney should be able to function normally. So are your filters filtering? We actually check this with a simple blood test called serum creatinine. And we use serum creatinine as a biomarker to estimate our glomerular filtration rate, or GFR. GFR is really the rate at which your blood is being filtered by the kidneys. Now, it's important to know that there's a newer biomarker known as cystatin C. This is quite a bit more expensive, much newer. So it's not done all the time. I might send a cystatin C once or twice a year on a child with chronic kidney disease, but it's more accurate than serum creatinine, but it's, serum creatinine does the bulk of our estimating for us. But just know that other biomarker is available. Some important caveats, regardless of your biomarker, creatinine or cystatin C, it's an estimate only, and so you have to be in steady state. So if you have acute kidney injury, we really don't want to try to use your blood test to assess your GFR. We just know your kidneys are sick, and hopefully they'll get better. And then once they get better, we try to estimate your GFR again. It's also important to know that creatinine is an imperfect biomarker, and it's based on muscle. So particularly in patients who might be deconditioned with like either muscle breakdown or they've been stuck in bed for a while, creatinine might underestimate their kidney disease. And so that's when we really want to think about using cystatin C. for tubular function, remember the tubule is the water treatment plant. This is where we look at the rest of the electrolyte panel and determine, okay, your electrolytes are well balanced. And then we can also look at the urinalysis and see if you can concentrate and dilute your urine. Then we know that you have pretty normal tubule function. So what's a normal filtration rate, or GFR, in the land of pediatrics? So one of the fun things about being a pediatric nephrologist is that you know, us adults are kind of boring in some ways, no offense. Our kidney function is fairly fixed over time, versus as children grow from birth through the first few years of life, it is vastly different what their kidneys should be doing, you know, on day 1 of life, day 2 of life. So it's much more dynamic and interesting. So first of all, as an adult, our GFR should be about 120 to 140. And this is in mils per minute per 1.73 meters squared. That's kind of an annoying unit, but it's the rate at which we're filtering our blood, and it's corrected for body surface area. So 1.73 meters squared is the average body surface area of an adult male. And then in pediatrics, if you're a term baby, your GFR is only about 30 mils per minute. And then if you're premature, it's even worse. Your GFR is only about 15 mils per minute. Interestingly, as an adult, if my GFR was 15 mils per minute, that would be called end-stage kidney disease, and I'd be on dialysis. But again, this is physiologic and normal for children. And regardless of your gestational age, your GFR doubles within about 2 weeks of life. And it's not because your kidneys are growing, it's just the blood flow improves postnatally to your kidneys, and so you filter more. You reach your adult norm of GFR by about 19 months of age. So this is important. If a pediatric nephrologist is following your child, if we know that your child has chronic kidney disease, we'll follow particularly closely if we think they have severe chronic kidney disease, but we can't really stage or determine what their overall prognosis is sometimes until about 2 years of age, where we know that their kidneys have fully blossomed into their adult normative values. And then hopefully we'll have a better sign of how they're going to do long term. So when we talk about chronic kidney disease, there are 5 stages. And again, this is all based on the estimate of glomerular filtration rate. And you can see that you can have stage 1 chronic kidney disease. Remember, you can't stage any child until they're about 2 years of age, so that we've accounted for their kidneys blossoming. But once they're about 2, we can start to stage them. And you can see you can have normal kidney function and still have chronic kidney disease at stage 1. And that just means that there's something abnormal radiographically. So the anatomy of your kidneys is abnormal, like maybe you might have a horseshoe kidney or cystic kidneys. And so that just means that they're not normally shaped or formed, but they have normal function. When we go up this kind of pyramid, you can see that you have worsening chronic kidney disease. And again, it's based on your estimated GFR. And so when we get up to stage 5 chronic kidney disease, this is the most severe stage. This is also known as end-stage renal disease or end-stage kidney disease. And that's when, you know, we need to think about dialysis or kidney transplant. Importantly, an adult nephrologist might not meet their patient with chronic kidney disease until they are nearing dialysis, so stage 4, stage 5. In pediatrics, if you have chronic kidney disease, a pediatric nephrologist needs to see the child. And the reason is that as they grow and develop, we need to make sure that their kidneys are keeping up with them. So sometimes, in particular, when children go through growth spurts, they can go from like stage 2 to stage 4 or stage 2 to stage 3. We have to keep a very close eye on them as they're growing to make sure that things are stable. And in general, as they kind of climb this pyramid, they need to see us more frequently. So I might see a patient with stage 1 chronic kidney disease once a year, maybe twice a year, versus if you have stage 5 or end-stage renal disease, you're seeing us at least once a month. So what can we do to preserve children's kidneys if they have chronic kidney disease, particularly from congenital anomalies of the kidney and urinary tract? So rule number 1, kidneys like to be wet. So it's really important that we keep kids well hydrated, particularly if they have that concentrating defect where they can't concentrate their urine very well. We need to make sure that they're hydrated. Rule number 2, kidneys don't like to work against pressure. And so it's really important that their bladder is being emptied and drained adequately. I know Dr. Wilcox spoke a lot about this earlier. And we, nephrology and urology, run joint clinics together because we co-manage a lot of these patients together. On the similar vein, we want to try to prevent urinary tract infections. And Dr. Wilcox probably spoke a little bit about this. It's really important to have good potty training hygiene, particularly like wiping from front to back rather than back to front. avoidance of constipation. If you can't empty your bowels very well, then your bladder doesn't empty fully, and that's a setup for infection. And sometimes we use timed voiding. That is, we specify how often someone should go to the bathroom and try to empty their bladder. And then it's really important that we have early suspicion and recognition of urinary tract infections. So if your child has an unexplained fever and they have a congenital anomaly of the kidney and urinary tract, it's really important to think about getting a urine culture and making sure they don't have an infection. And then finally, there's just kind of common sense avoidance of medications that can hurt the kidneys. If you need a medication, absolutely take it. But some over-the-counter medications that we don't really have to have, there are other alternatives, can hurt the kidneys. So one of the most common examples is non-steroidal anti-inflammatory drugs, also known as ibuprofen, Advil, Motrin. So if your child has chronic kidney disease and they have a fever, our preference would be that you reach for acetaminophen, paracetamol, Tylenol versus ibuprofen, Advil, or Motrin. And so we actually have wallet warning cards that we give out in clinic, kind of, they're available in English and Spanish, just kind of giving you kidney safe medications and then kind of kidney caution medications. Call us first before you use them, and also medications to avoid, such as ibuprofen. And I think that that's what I had to discuss today, but I'm happy to take any questions if anyone has any, and here's email if anything pops up later. Thank you.